In assessing a trauma patient, what are the critical components of the primary survey and how should you prioritize airway management in a patient with suspected cervical spine injury? Answer: the primary survey is essential in trauma assessment following the ABCDE approach: airway, breathing, circulation, disability, exposure, airway management. Ensure airway patency using techniques like the head tilt, chin lift, or jaw thrust. In suspected cervical spine injuries, the jaw thrust is preferred to avoid exacerbating the injury. Advanced airway agents such as oropharyngeal OPA and nasopharyngeal airways (NPA) may be utilized based on the patient's level of consciousness. The OPA is contraindicated in conscious patients as it may induce gagging. Breathing assessment: evaluate respiratory rate, depth, and effort using auscultation to identify abnormal lung sounds such as wheezes or crackles, which indicate potential obstructive or restrictive processes. Circulation assessment: identify shock states, hypovolemic, cardiogenic, obstructive, distributive, by assessing peripheral circulation through capillary refill time and pulse quality. Disability assessment: utilize the AVPU scale to assess the patient's neurological status and perform a neurological examination focusing on pupil response and limb movement. Exposure environmental control: carefully remove clothing while ensuring patient dignity and manage hypothermia as indicated. This systematic approach allows for the rapid identification and management of life-threatening conditions. What are the signs and classifications of shock that a clinician should recognize during a physical examination, and how do these findings influence initial management? Answer: clinicians must identify shock types based on vital sign abnormalities and clinical presentation. Signs of shock: hypotension. Low blood pressure indicates decreased perfusion. Normal systolic blood pressure is around 9 mmHg. Achycardia. Increased heart rate 100 bpm is a compensatory mechanism. Altered mental status, confusion, or lethargy can suggest inadequate cerebral perfusion. Cool, clammy skin indicates peripheral vasoconstriction in response to shock. Classifications of shock: hypovolemic shock, caused by significant blood or fluid loss, e.g., hemorrhage characterized by rapid heart rate and low blood pressure. Cardiogenic shock, resulting from pump failure, e.g., myocardial infarction presenting with pulmonary congestion and elevated jugular venous pressure. Obstructive shock, due to mechanical obstruction, e.g., tension pneumothorax indicated by hypotension and altered respiratory status. Distributive shock, often seen in septic shock characterized by vasodilation leading to warm extremities despite hypotension. Initial management requires addressing the underlying cause. Fluid resuscitation for hypovolemic shock, oxygenation, and in some cases, the use of vasopressors for distributive shock. Explain the significance of complete blood count (CBC) parameters in assessing a patient in the emergency department. How do abnormalities in these parameters guide your management decisions? Answer: a CBC provides critical insights into a patient's hematological status. White blood cell (BE) elevated levels, leukocytosis, can indicate infection or inflammation, while low levels, leukopenia, may suggest bone marrow suppression or overwhelming infection. Hemoglobin, HB, and hematocrit, HET. Low hemoglobin levels can indicate anemia or acute blood loss. Management may involve fluid resuscitation and transfusion, particularly if HB falls below 7-8 grams, still a stable patient, or lower in those with active bleeding or significant symptoms. Platelets. Thrombocytopenia may increase bleeding risk, impacting decisions about surgical interventions or invasive procedures. The interpretation of these parameters allows for tailored management, including the initiation of antibiotics in suspected infection or transfusion in cases of significant hemorrhage. Describe the indications for computed tomography (CT) scans in trauma patients and the implications of contrast versus non-contrast studies in emergency settings. Answer: CT scans are invaluable in trauma assessment. Indications: head CT is indicated in patients with altered mental status or suspected intracranial injury. Chest CT is used to evaluate for vascular injury or pneumothorax, especially in patients with rib fractures. Abdominal CT is crucial for assessing solid organ injuries, free fluid, or hemorrhage. Contrast versus non-contrast studies. Non-contrast CT is for quickly identifying fractures or hemorrhagic events in the brain. Contrast CT enhances visualization of vascular structures and soft tissues, essential for detecting active bleeding or vascular injury, but carries a risk of anaphylaxis and nephrotoxicity, particularly in patients with renal impairment. Understanding these implications guides appropriate imaging protocols to optimize patient outcomes while minimizing risks. Mr. Thompson, a 58-year-old male, presents to the emergency department after a fall from a height. He is confused as a GCS of 12 and exhibits a widened pulse pressure of 158 mmHg. What should be your immediate management steps considering his potential injuries and vital sign abnormalities? Answer: immediate management for Mr. Thompson should focus on stabilizing his airway, breathing, and circulation. Airway management. Given his GCS of 12, he may require airway protection. If there are signs of respiratory distress or a reduced level of consciousness, intubation may be necessary. Breathing and circulation assessment. Administer supplemental oxygen to maintain oxygen saturation above 94%. Monitor vital signs closely. The widened pulse pressure suggests potential head trauma or increased intracranial pressure. Prepare for fluid resuscitation if indicated. Neurological assessment. Continuously assess his GCS and perform a rapid neurological examination. Given the fall, consider a CT scan of the head to evaluate for intracranial hemorrhage. Further investigations. Initiate a CBC, BMP, and COGS to assess for potential internal bleeding. Obtain a chest X-ray to rule out pulmonary contusions or rib fractures. Discuss the criteria for utilizing advanced airway adjuncts in emergency situations, particularly in cases of severe respiratory distress. Include the considerations for oropharyngeal versus nasopharyngeal airways. Answer: advanced airway adjuncts are critical in managing severe respiratory distress. Oropharyngeal airway OPA, indicated for unconscious patients without a gag reflex. It prevents airway obstruction due to the tongue and allows for effective ventilation. Contraindications include conscious patients as it may induce gagging and airway compromise. Nasopharyngeal airway NPA can be used in both conscious and unconscious patients. It is particularly beneficial in situations where OPA cannot be placed due to the presence of facial trauma. Caution is required in patients with potential skull base fractures as it may enter the cranial cavity. Selecting the appropriate adjunct is based on patient responsiveness, level of consciousness, and potential for airway obstruction. Continuous assessment of airway patency is essential, and readiness to intubate should be maintained if adjuncts fail to secure the airway. What is the role of the secondary survey in trauma assessment, and what systematic approach should be utilized to ensure a comprehensive evaluation of the patient? Answer: the secondary survey is crucial for identifying non-life-threatening injuries following the primary survey. Systematic approach. Utilize a head-to-toe examination to identify injuries systematically. Start with head and neck. Examine for lacerations, fractures, and neurological deficits. Chest and abdomen. Assess for contusions, crepitus, and abdominal tenderness. Pelvis and extremities. Palpate for tenderness, instability, or deformities. Check pulses and motor function in limbs. Detailed history taking. Use the AMPLE, mnemonic allergies, medications, past medical history, last meal, events leading to present illness, to obtain a focused history that can inform treatment decisions. Documentation. Ensure thorough documentation of all findings, including vital signs and any interventions performed. Use standardized assessment tools like the Glasgow Coma Scale for neurological assessments to communicate effectively with other healthcare providers. Describe the pediatric assessment triangle PAT and its application in evaluating children in emergency situations. What specific signs would indicate a need for immediate intervention? Answer: the pediatric assessment triangle is a rapid assessment tool used to evaluate critically ill or injured children, focusing on three key areas: appearance, assess mental status, and overall appearance. Signs of poor appearance include lethargy, decreased responsiveness, and abnormal tone, indicating potential respiratory or neurological compromise. Breathing. Evaluate respiratory effort and effectiveness. Observe for abnormal sounds, stridor, wheezing, increased work of breathing, retractions, nasal flaring, and cyanosis, which necessitate immediate intervention. Circulation to skin. Inspect skin color and temperature. Signs of poor circulation include pallor or mottled skin, indicating shock or inadequate perfusion, requiring urgent resuscitative measures. Immediate interventions based on PAT findings may include supplemental oxygen, airway management, or volume resuscitation, depending on the severity of the child's condition. Discuss the emergency pharmacology principles when managing anaphylaxis. What medications are crucial in the acute management, and what are their mechanisms of action? Answer: anaphylaxis is a life-threatening allergic reaction that requires prompt pharmacological intervention. Epinephrine, administered intramuscularly 0.3–0.5 mg for adults, 0.1 mg for children. Mechanism of action: Epinephrine causes vasoconstriction, increasing systemic vascular resistance and blood pressure. It also relaxes bronchial smooth muscle, improving respiratory function and counteracting histamine release. Antihistamines e.g. diphenhydramine, while they do not reverse anaphylaxis, they can help alleviate symptoms like hives and itching. Corticosteroids e.g. methylprednisolone, administered to reduce the likelihood of biphasic reactions, though their effects are not immediate. Bronchodilators e.g. albuterol, indicated if bronchospasm persists despite epinephrine administration. Immediate recognition and treatment with epinephrine is critical in managing anaphylaxis, along with supportive care and monitoring. Outline the management protocols for a patient presenting with a suspected tension pneumothorax. What are the key steps in diagnosis and treatment? Answer: tension pneumothorax is a critical condition requiring immediate intervention. Diagnosis: clinical suspicion based on signs of respiratory distress, hypoxia, hypotension, and hyperresonance on percussion of the affected side, absent breath sounds on auscultation over the affected lung. Immediate treatment: needle decompression. Use: a large bore cannula, 14 gauge or larger, inserted in the second intercostal space at the midclavicular line of the affected side. This allows trapped air to escape and relieves pressure. Chest tube insertion: after needle decompression, place a chest tube for continuous drainage of air or fluid and to re-expand the lung. Monitoring and support: continuous monitoring of vital signs and respiratory status is crucial post-intervention. Administer supplemental oxygen as needed and consider fluid resuscitation for any associated hypovolemic shock. Describe the primary and secondary survey and trauma assessment. How do these surveys guide the management of a trauma patient? Answer: the primary survey is the initial assessment aimed at identifying life-threatening conditions using the ABCD approach. Airway: ensure the airway is clear, assess for obstruction. Breathing: evaluate the effectiveness of breathing and look for signs of respiratory distress. Circulation: assess the pulse, blood pressure, and skin perfusion to detect shock. Disability: perform a quick neurological assessment using the AVPU scale. Alert, verbal, pain unresponsive. Exposure environment: completely expose the patient to identify injuries while preventing hypothermia. The secondary surveys: a more comprehensive evaluation performed after the primary survey and initial resuscitation, focusing on obtaining a thorough history using the SAMPLE acronym. Signs, symptoms, allergies, medications, past medical history, last oral intake, events leading to the injury, and performing a head-to-toe physical examination. What criteria should be used to determine the appropriate triage level for a trauma patient? Discuss the indications for helicopter versus ground transport. Answer: triage is crucial in ensuring that patients receive the appropriate level of care based on the severity of their injuries. Criteria for triaging patients include mechanism of injury. High-energy mechanisms such as motorcycle accidents or falls from significant heights typically require higher-level care. Physiological status: a patient with altered mental status, Glasgow Coma Scale 14, respiratory distress, or signs of shock e.g. hypertension is a priority for advanced trauma care. Anatomical criteria: injuries to the head, neck, chest, abdomen, pelvis, or major vascular structures necessitate immediate transport to a trauma center. Transport indications: helicopter transport, indicated for patients with severe injuries located far from trauma centers or when time is critical, such as in cases of massive hemorrhage or severe head injuries. Grunt transport, suitable for patients who are stable but still require transport to a facility equipped to handle their injuries. Explain the assessment and management of a patient with suspected tension pneumothorax. What are the critical steps in intervention? Answer: a tension pneumothorax occurs when air enters the pleural space and cannot escape, leading to increased intrathoracic pressure and compromised cardiovascular function. Assessment: clinical signs. Look for tachypnea, decreased breath sounds on the affected side, tracheal deviation away from the affected side, and hypotension. Imaging: a chest X-ray or ultrasound may be used for confirmation, but clinical diagnosis often necessitates immediate intervention. Management: needle decompression. The immediate intervention involves inserting a large bore needle, 14 gauge or larger, into the second intercostal space at the midclavicular line on the affected side to release trapped air. Chest tube insertion. After initial decompression, the definitive management is placing a chest tube in the fifth intercostal space at the anterior axillary line for continuous drainage of air or fluid. Differentiate between solid and hollow organ injuries in abdominal trauma. What are the indications for exploratory laparotomy versus non-operative management? Answer: abdominal trauma can result in injuries to either solid organs, G. Liver, spleen, kidneys, or hollow organs. G. Stomach, intestines, solid organ injuries. These often result in internal bleeding. Indicators for surgical intervention include hemodynamic instability despite fluid resuscitation, presence of significant lacerations or fractures on imaging, hollow organ injuries. These can lead to peritonitis due to the spillage of contents. Indications for surgical intervention include signs of peritonitis. G. Rigidity, rebound tenderness, free air on imaging indicative of perforation, non-operative management in stable patients with solid organ injuries, especially spleen or liver. Non-operative management may involve close observation, bed rest, and serial hemoglobin checks, as many of these injuries can heal without surgery. Mr. Thompson is a 65-year-old male who fell from a height of 10 feet and presents with neck pain and decreased strength in his right arm. He has a Glasgow Coma Scale score of 14. What are the steps you should take in managing Mr. Thompson's condition? Answer: given Mr. Thompson's mechanism of injury and neurological symptoms, the following steps should be taken. Stabilization. Apply a cervical collar to immobilize the neck and prevent further injury. Primary survey. Conduct a thorough primary survey to assess airway, breathing, and circulation. Neurological assessment. Evaluate his neurological status more closely, considering the potential for spinal cord injury. Imaging. Obtain imaging studies, such as a CT scan of the cervical spine, to evaluate for fractures or spinal cord compromise. Consultation. Depending on imaging results, consult neurosurgery or orthopedic surgery if a significant injury is identified. Monitoring. Continuous monitoring of neurological status and vital signs is critical, as changes can occur rapidly. Guidelines. Following ATLS protocols, early identification and management of cervical spine injuries are crucial to prevent irreversible damage. Discuss the classification of burns and the associated fluid resuscitation protocols, particularly focusing on the Parkland formula. Answer: burns are classified based on depth. First-degree burns affect only the epidermis and cause redness and pain, but typically do not require medical intervention. Second-degree burns involve the dermis are present with blisters and significant pain, may require medical treatment depending on the extent. Third-degree burns extend through all layers of skin, appear white, charred, or leathery, and require surgical intervention. Fluid resuscitation. The Parkland formula is used to calculate fluid needs for burn patients. Total fluid requirement for %, x body weight, kg. Guidelines. According to the guidelines, half of the total fluid should be given in the first 8 hours post-injury and the remaining half over the next 16 hours. Monitoring for complications such as fluid overload, infection, and respiratory failure is vital. What unique considerations should be taken into account when managing trauma patients who are pregnant? Answer: managing trauma in pregnant patients requires special considerations. Physiological changes. Pregnant patients experience hemodynamic changes, a blood volume increases, and vital signs can vary from non-pregnant adults. Fetal monitoring. Assess fetal heart tones and gestational age, as the well-being of the fetus is critical. Mechanism of injury. The type and mechanism of trauma may affect both the mother and fetus differently. For example, a seatbelt can cause uterine injury. Positioning. In cases of significant trauma, left lateral positioning is recommended to prevent aortocaval compression, optimizing maternal and fetal perfusion. Guidelines. Consult the appropriate guidelines for trauma management in pregnant patients, which emphasize both maternal and fetal health. Outline the steps for managing a patient in hemorrhagic shock due to traumatic injury. What specific interventions are crucial for survival? Answer: in managing a patient with hemorrhagic shock, immediate and effective intervention is critical. Assess hemodynamic status, monitor blood pressure, heart rate, and signs of perfusion, capillary refill, mental status. Initiate IV access, establish large bore intravenous Roman access, and begin aggressive fluid resuscitation with crystalloids, the normal saline or lactated ringers. Massive transfusion protocol MTP. Activate MTP if the patient shows signs of massive hemorrhage, allowing for rapid access to blood. PRODS, DECS, FFP, platelets. Identify and control the source of bleeding. Utilize direct pressure, tourniquets, or surgical intervention. Exploratory laparotomy to control bleeding. Monitor laboratory values. Serial hemoglobin and coagulation profiles should be closely monitored to assess the need for further interventions. Guidelines. Following the latest ATLS guidelines, the concept of early control of hemorrhage significantly improves outcomes in trauma patients. When is chest tube insertion indicated in trauma patients, and what are the critical steps involved in the procedure? Answer: chest tube insertion is indicated for tension pneumothorax, large pleural effusions, hemothorax. Steps for chest tube insertion: preparation. Gather necessary equipment including a chest tube kit, sterile gloves, and local anesthetic. Positioning: place the patient in a supine or semi-Fowler's position with the arm raised above the head on the side of insertion. Site selection: identify the fifth intercostal space at the anterior axillary line for insertion. Anesthesia: administer local anesthetic at the insertion site. Incision and insertion: make a small incision approximately 1-2 centimeters and dissect through the subcutaneous tissue to reach the pleural space. Insert the tube, usually 2-4-3-2 FR, into the pleural cavity, ensuring it is directed posteriorly and laterally. Securing the tube: connect to a drainage system, secure the tube with sutures, and monitor for effective drainage. After initiating fluid resuscitation in a burn patient, what complications should be monitored for, and how can they be addressed? Answer: post-resuscitation complications include fluid overload. Monitor for signs of pulmonary edema, G. dyspnea, hypoxemia, and jugular venous distension. Use diuretics, G. furosemide if fluid overload occurs. Infection: burn wounds are at high risk for infection. Monitor for changes in temperature, wound appearance, and leukocytosis. Administer appropriate antibiotics based on culture results. Respiratory failure: due to inhalation injuries or fluid overload, watch for signs of respiratory distress and consider bronchodilators or intubation as necessary. Renal failure: monitor urine output and renal function tests, as significant fluid shifts can impact renal perfusion. Guidelines: adhere to established burn management protocols to identify and mitigate complications, promptly ensuring a multidisciplinary approach to patient care. Explain the pediatric assessment triangle pattern. Describe how it helps in the evaluation of a pediatric patient in an emergency setting. Answer: the pediatric assessment triangle pad is a systematic approach used to assess the stability of a pediatric patient quickly. It consists of 3 components: appearance, work of breathing, and circulation to the skin. Appearance: this includes assessing the child's responsiveness, tone, and interaction. Signs of poor appearance may include lethargy, irritability, or lack of interaction, indicating a potential emergency. Work of breathing: this evaluates the respiratory effort of the child. Signs such as tachypnea, retractions, grunting, or nasal flaring suggest respiratory distress. Circulation to the skin: this component assesses the perfusion status, which can be gauged through skin color, pallor, cyanosis, temperature, and capillary refill time. By using the PAT, emergency responders can quickly identify whether a child is stable, requires immediate intervention, or needs further evaluation. The guidelines from the American Academy of Pediatrics emphasize the importance of rapid assessment to initiate timely treatment, especially in cases of respiratory distress or altered mental status. What are the key differences in CPR techniques for infants, children, and adolescents according to the Pediatric Advanced Life Support (PALS) guidelines? Answer: the PALS guidelines highlight significant differences in CPR techniques based on the age of the pediatric patient. Here are the distinctions. Infant 0-1-2 months. Compression technique: use 2 fingers for chest compressions, placing them just below the nipple line. The compression depth should be approximately 1.5 inches, 4 centimeters. Compression to ventilation ratio: perform 30 compressions followed by 2 breaths. Ventilation technique: use a barrier device or bag mask ventilation, ensuring a proper seal. Children 1 year to puberty. Compression technique: use 1 or 2 hands depending on the rescuer's strength. For compressions, at least 2 inches, 5 centimeters in depth. The hands should be placed on the lower half of the sternum. Compression to ventilation ratio: maintain a 30-to ratio if alone. If there are 2 rescuers, use a 15-to ratio. Ventilation technique: similar to infants, but ensure that breaths are given over 1 second and result in visible chest rise. Adolescents, puberty onwards. Compression technique: use adult techniques. 2 hands compressing the chest to a depth of at least 2 inches, 5 centimeters. Compression to ventilation ratio: follow the adult guideline of 30-to. Ventilation technique: use a bag mask device for effective ventilation. These guidelines aim to optimize the effectiveness of CPR and ensure proper oxygenation and perfusion for pediatric patients in different age groups. Describe the management protocols for asthma exacerbations in pediatric patients and indicate when hospitalization may be necessary. Answer: management of asthma exacerbations in pediatric patients involves a stepwise approach. Initial assessment: evaluate the severity of the exacerbation using peak expiratory flow, PEF measurements, and clinical signs, G. Respiratory rate, use of accessory muscles, oxygen saturation. Bronchodilator therapy. Administer short-acting beta-agonist SABA, such as albuterol via nebulizer or metered-dose inhaler (MDI). The initial dose can be 2.5 mg via nebulizer or 90180 mg via MDI. Corticosteroids. In moderate to severe exacerbations, administer systemic corticosteroids e.g. prednisone EDTA for 3-5 days to reduce inflammation. Monitoring. Continuous monitoring of respiratory status, heart rate, and oxygen saturation should be performed. Indications for hospitalization: severe respiratory distress despite treatment, hypoxemia, SPO 92% on room air, inability to maintain adequate hydration or nutrition. Discuss the management of croup in a pediatric patient, including both home care recommendations and indications for emergency intervention. Answer: croup, characterized by a distinctive barking cough and stridor, is commonly caused by viral infections. Management strategies include mild croup, home care, use of humidified air, e.g. cool mist humidifier or a steamy bathroom can help relieve symptoms. Oral hydration and rest are also recommended. Moderate to severe croup assessment. Patients showing stridor at rest or significant respiratory distress should be evaluated in the emergency department. Dexamethasone. Administer oral dexamethasone 0.6 mg, a single dose to reduce airway inflammation. Nebulized epinephrine. For severe cases, nebulized racemic epinephrine can be used to relieve acute airway swelling, monitored for potential rebound effect. Indications for hospitalization: presence of stridor at rest, severe respiratory distress, or inability to maintain adequate hydration. Patients requiring close monitoring or repeated doses of nebulized epinephrine may need admission. The American Academy of Pediatrics guidelines outline these protocols, emphasizing the importance of timely intervention to prevent complications in pediatric patients with croup. A 5-year-old boy presents to the emergency department with signs of dehydration after a 2-day history of vomiting and diarrhea. What is the most appropriate management strategy for this patient, and what factors would indicate the need for intravenous rehydration? Answer: for a 5-year-old boy presenting with signs of dehydration due to gastroenteritis, the management strategy should begin with a thorough assessment of dehydration severity. Assessment: evaluate the child's weight loss, vital signs, and clinical signs, e.g. dry mucous membranes, decreased urine output, capillary refill time. Oral rehydration therapy, or for mild to moderate dehydration, administer an oral rehydration solution ORS such as Pedialyte. The typical initial rehydration regimen is 5-0-10 or g over 4-6 hours. Encourage small, frequent sips rather than large volumes to enhance tolerance. Intravenous rehydration indicated in cases of severe dehydration, e.g. 10% weight loss, or when the child shows signs of shock, e.g. tachycardia, hypotension. Oral rehydration is not tolerated, e.g. persistent vomiting, severe electrolyte imbalances, or lethargy is present. Describe the critical differences in the approach to managing an infant with respiratory distress due to bronchiolitis versus a child with asthma exacerbation. Answer: the management of respiratory distress in infants with bronchiolitis differs significantly from that of children with asthma exacerbation. Bronchiolitis, usually viral, etiology. Initial assessment: focus on the severity of respiratory distress, hypoxia, and hydration status. Supportive care: administer nasal suctioning to clear secretions, provide supplemental oxygen if SPO 90%, and monitor closely for worsening respiratory status. Bronchodilators and steroids. The use of bronchodilators is generally not recommended as routine treatment, and systemic corticosteroids are not indicated unless there is a coexisting condition like asthma. Indications for hospitalization: severe respiratory distress, hypoxemia, or dehydration warrant inpatient care. Asthma exacerbation. Initial assessment: evaluate the patient's PEF and severity of symptoms, e.g. wheezing, chest tightness. Bronchodilator therapy. Administer SABAE, albuterol for rapid relief. Systemic corticosteroids may also be indicated in moderate to severe cases. Indications for hospitalization: persistent symptoms despite treatment, hypoxemia, or frequent exacerbations indicate the need for inpatient management. These management differences reflect the underlying pathophysiology of the conditions as outlined in the guidelines from the National Heart, Lung, and Blood Institute (SHI) and the AAP. Explain the importance of differentiating between viral and bacterial gastroenteritis in pediatric patients and the implications for treatment. Answer: differentiating between viral and bacterial gastroenteritis in pediatric patients is crucial for appropriate management. Viral gastroenteritis Common etiologies: rotavirus, norovirus, and adenovirus are typical causes. Management: focus on supportive care with oral rehydration. Antibiotics are not indicated as viral infections are self-limiting. Bacterial gastroenteritis: common bacterial agents: Salmonella, Shigella, E. coli, especially enterotoxigenic strains. Management: in cases of bacterial gastroenteritis, particularly when severe dehydration or bloody diarrhea occurs, empiric antibiotic therapy may be warranted. Indicators for antibiotics: the presence of high fever, severe abdominal pain, and blood in stool necessitates further investigation, e.g., stool cultures and possible antibiotic treatment. In the case of a pediatric patient who has sustained blunt abdominal trauma, what are the key considerations for the assessment and management of potential organ injuries? Answer: in a pediatric patient with blunt abdominal trauma, the following considerations are crucial for assessment and management. Initial assessment: conduct a primary survey focusing on airway, breathing, circulation, and disability. Evaluate vital signs and perform a thorough physical examination looking for signs of internal bleeding, e.g., abdominal tenderness, distension, or guarding. Imaging studies: use ultrasound fast exam to quickly assess for intra-abdominal fluid or organ injury. If ultrasound findings are inconclusive, a CT scan may be necessary for detailed evaluation. Be cautious with radiation exposure, especially in children. Indications for surgical intervention: persistent hypotension or evidence of peritonitis may indicate the need for exploratory laparotomy. Solid organ injuries, e.g., liver or spleen laceration, may often be managed conservatively with monitoring, as many children can tolerate them well without surgical intervention. What are the early signs of sepsis in pediatric patients, and what immediate management steps should be taken in the emergency department? Answer: early signs of sepsis in pediatric patients can be subtle and include fever or hypothermia, especially in neonates, altered mental status or lethargy, tachycardia or tachypnea, skin changes such as mottling or a rash. Immediate management steps. Sepsis protocol: initiate a sepsis protocol including rapid assessment of vital signs and clinical status. Blood cultures and laboratory testing: obtain blood cultures before starting antibiotics to identify the causative organism alongside CBC electrolytes and lactate levels. Fluid resuscitation: administer isotonic fluids, e.g., normal saline rapidly 20 mg bolus to improve perfusion and stabilize blood pressure. Antibiotic therapy: start broad-spectrum intravenous antibiotics within the first hour of suspected sepsis, e.g., ceftriaxone, vancomycin, while awaiting culture results. Monitoring: continuous monitoring of vital signs and laboratory values is essential to guide further management and assess the response to treatment. Discuss the principles of effective pain management in pediatric patients and the role of pharmacologic and non-pharmacologic interventions. Answer: effective pain management in pediatric patients involves several key principles. Assessment: use age-appropriate tools to assess pain levels, e.g., Wong-Baker FACE S pain rating scale for older children, FLACC scale for infants. Pharmacologic interventions: non-opioid analgesics, acetaminophen or ibuprofen is often the first line for mild to moderate pain. Opioids: for severe pain, opioids, e.g., morphine, may be used, ensuring careful dosing and monitoring for side effects, particularly respiratory depression. Non-pharmacologic interventions: utilize techniques such as distraction, relaxation strategies, and parental presence to help manage pain and anxiety. Cognitive behavioral therapy and guided imagery can also be effective adjuncts in pediatric pain management. Guidelines: the American Academy of Pediatrics recommends a multimodal approach to pain management, emphasizing the importance of treating pain aggressively while balancing the risks of opioid use.